Good morning, everybody. I'd like to introduce the speaker for our session, Dr. April Baller. And Dr. Baller is the Infection Prevention and Control and the WASH Team Lead at the Health Emergencies Program at the World Health Organization based in Geneva, Switzerland. And she has over 25 years experience in dealing with many infectious diseases and pandemics, including the COVID-19, and April will be talking to us this morning about lessons learned during the pandemic, particularly from the infection prevention and control point of view. April, thank you for being with us.
Great, thank you so much. Good morning to everyone, and thanks for being here this morning. And just to say that it's been a real pleasure to prepare this presentation because I actually started my first outbreak in the Ebola outbreak in 2014 in Liberia, which is almost 10 years ago. So going through this, preparing for this, and reading some of the articles has also been a personal journey. So thank you for taking this with me. So the first and most important question on everyone's mind, I'm sure, is this. I didn't actually see the results this morning, but I just heard something, so thanks to colleagues. But no, let's get on to more serious question. The real question this morning for all of you to consider as we go through this, presentation briefly is, are we safer and better prepared for the next pandemic? And I'd like you to think about this, and we'll come back to this question at the end. So the issue really is, and really preaching to the preached here, is the IPC and public health community need to learn from previous outbreaks and pandemics to be better prepared for future pandemics. So the outline will briefly just touch on why this is important, the challenges and lessons learned, not just from COVID, but from other outbreaks, and importantly, what are the mitigation measures that have been put in place, what are the policies, some of the reforms and the tools, and this is both at global level and at national and facility level. So here, what's important is to see, first of all, that we have increasing frequency, scaled, and impact of public health outbreaks and epidemics and pandemics. You're seeing this on the bottom right. And then on the top left, you can see there what's interesting, of course, is that about 70% of all of these epidemics are actually zoonotic, and this has really been something that has been on the increase really over the last 20 to 30 years, so it's relatively new. But of course, with the globalization, migration, all of this is now taking on effect. So, what are the IPC risk factors during an infectious disease outbreak? I'm going to go through these 4 different areas very briefly. Firstly, of course, the amplification of pathogens within the healthcare facilities. So infections usually start within the community. When they then, patients come to the facility, if the IPC measures and WASH measures are not in place, this can then lead to the transmission back into the community, and that's amplified, which is what happened during the COVID pandemic. Here is an interesting example of what happened during the Ebola outbreak in DRC from 2018 to 2020, and what you can see here is the background gray is the community cases of Ebola, and then what is of interest is in the blue, this is the number of nosocomial cases that occurred, and proportionally at the first period and second period this was very low, but at the third period, what you're seeing here, was actually there was a high proportion of nosocomial infections, and this prolongated the outbreak. So next is to speak about the increase of healthcare worker infections. Of course, we all know that this occurred during the COVID pandemic. Interestingly, there is not that much data on it. What you can see here is this is from the WHO dashboard, which was actually discontinued in November 2023. It shows there was representation from all the regions, 123 countries. However, it was because it was voluntary, it was very sporadic, and we don't really have a good insight, but it was clear that at the beginning of the pandemic, the proportion of healthcare workers' infections were high. And why were they high? This is a publication which was a case control study in 121 health facilities in 21 countries, only at the beginning from 2020 to 2021. And really what this showed was that the risks were associated with not adhering to personal protective guidelines and not consistently performing hand hygiene after patient contact. Additionally, close contact with COVID patients for a prolonged period of time was of increased risk. And then finally, lower risk was linked to using respirators during AGPs and gloves, gowns, and coveralls during contact. So in conclusion, appropriate IPC measures and PPE use remain a priority to protect health workers from SARS, which you're all aware of. Then in the context of Ebola and Marburg disease, I think this is interesting publication which was from the Sudan virus disease in Uganda, and really what it showed here was that at the very beginning of the outbreak, before it was actually declared, there was a lot of health workers who were infected, and what you can see on the graph on the right hand side is basically showing each of those cases and how they were linked. So it was 2 nosocomial infections that occurred within the hospital that led to these infections. And what it's saying is that health workers are vulnerable to infections, and that early on, when we have a low suspicion, that's even a higher risk. Another publication looked at this one is below, and this one really showed that when there are the resources are in place, the transmission is low. This was a review which was trying to understand better around nosocomial transmission. But it was taken, really, the only evidence that was there was data that was taken from an Ebola treatment unit that was set up later on during the outbreak. So it's emphasizing the lack of quality evidence for African healthcare settings to assess the occupational exposure. And then finally here we have the Rwanda Marburg outbreak, which is ongoing. Interestingly, there has been 66 confirmed cases, and although the data is not available, it is understood that over 80% of this was due to health workers who were infected in 2 of the main hospitals in Kigali. So this is just to emphasize the importance of early measures, high suspicion, and that it's important to implement IPC standards and transmission-based precautions at all time based on risk assessment. And here, this is an example from health worker infections in MERS, and what it's showing, interestingly, is that there's a lot of asymptomatic transmission, and this is very challenging. But what they did do here was that once they identified the number of cases, mainly which happened in the emergency department, then they put in place what they call this infectious disease epidemic plan, and you can see the errors of the epi curve, which was really about putting strong IPC measures in place, and that once they were put in place, the caseload dropped. So now on to the risk for healthcare-associated infections. So of course there was increased there was increased healthcare-associated infections during COVID. And this nice paper shows the significant increase in CLABSI 4 times incidence increase, CAUTI 2.7, and then MRSA 3 times during the COVID pandemic. And then finally on AMR, which is what you're all experts on here more than me, so I won't spend too much time on this, but obviously showing that during the pandemic there was a high increase due to increased use of antibiotics and the challenges with IPC measures. So what are the lessons that we've learned? We have learned some things we have and some things we're still learning. This is an interesting paper back from 2000 and 2005, and it was on the SARS-1 outbreak in 2003, which had a high attack rate of healthcare workers, over 50%. And really the lessons learned there are ones that we are still listening to and hearing today about implementing stringent precautions during a crisis, but not just when it starts, but maintaining it, ensuring that health workers are vaccinated. This hospital surveillance should be expanded. And finally, the importance of early diagnosis, not only to identify cases, but to reduce unnecessary isolation, contact tracing, and anxiety. Other lessons really with looking at Ebola. This is a really nice paper from Sierra Leone, and what it shows is that during the 2015 Ebola outbreak, this was an entry point, an opportunity to actually establish the IPC program, which is still in place and has been quite robust since then. Here are another couple of papers on the Ebola outbreak, lessons learned. I think on the right-hand side, an interesting publication on pay for performance as a strategy to increase adherence to IPC measures. And it showed a significant increase. However, this was only over an 8-week period, so it would be very interesting to look at that again. However, on a positive note, some cross-cutting lessons. This was a review done by Dembek, which shows that with time and experience and having more resources available, whether they are vaccines, antiviral therapy, public health measures, or coordination mechanisms, there seems to be a quicker response and containment of these outbreaks. Moving on to another area around quarantine and isolation during different types of outbreaks. This was a review with 24 articles, and it really showed the challenges of implementing this, human resources, infrastructure shortages, and of course the social and psychological burden. And in conclusion, in the context of Africa, this was showing that due to low human capacity and limited health systems, it's difficult to implement this in complex public health emergencies. Now we're moving on to look at a little bit of lessons learned around COVID and IPC. This was a nice paper that was published actually at the beginning of the COVID outbreak, and it was a survey that was done with two IPC specialists, their perceptions on whether or not they were prepared. And this was the 4 key areas they identified. It's potential challenges, the shortages of PPE, the negative impact of media on guideline development, which I found quite interesting, the perception that guidelines were being developed based on maximum security versus evidence-based. Of course, there was no evidence at the time. And then the heightened focus on the type of mask being used, which was creating a false sense of security. And then, of course, the uncertainties around the modes of transmission for IPC recommendations. I just thought this was very nice because this actually is what really played out later on during the COVID pandemic. Here is a recent evaluation the WHO requested to see what were the lessons learned for WHO with respect to many of the key areas that they were working on during the COVID pandemic. Guidelines, providing training materials and risk communications. And the feedback really was that the guidelines actually were trusted and they were used and helped to implement policy change. They were rigorous, and that through the collaboration of different regions, they were adopted and adapted. So despite a lot of the concerns about updating guidelines, it seems that they were still well received and utilized. And the training that was provided, which was free, was incorporated into courses at country level. And then with respect to risk communication, that these were user-friendly. So it was just a kind of affirmation that it is important to have these type of products. However, monitoring and evaluation is required. And then this publication really is looking at shifting more over onto IPC programs. But really what it's showing is that, that interestingly, which we know, but maybe there's not been so much publications on it, is around the contribution of programs to waste. And this is, of course, during routine health service delivery, but in particular, this was highlighted and a major concern during the COVID-19 pandemic with the utilization of PPE. And they recommend effective leadership, partnership, engagement, and the community activation to really strengthen IPC moving forward. And then finally here on a lessons learned, which is also linked to Africa, and I think this is quite interesting because this is now operational. It was the role of the Africa CDC to take on the leadership for future pandemics, the importance of having political commitment, partnerships, and of course increased investment in health workers. So this has now been operationalized during the Mpox multi-country outbreak. And then finally here, just an interesting piece looking now at the H5N1, and even though we seem to be learning, this is raising the alarm that, you know, are we moving ahead? Are we moving one step forward, two steps back, or the other way around? And some of the negative impact from COVID and how this could potentially impact putting in policies in the future, in particular around school closures, masking policies. So, moving forward, what has the global public health community done as mitigation measures? And here is a nice piece that was published by the WHO Afro Regional Director, Dr. Moti, and really emphasizing the importance of learning the lessons and building a stronger, more sustainable system moving forward, the global architecture for health emergencies. And here is just to show, this is also a really nice, actually it's a book, and it's showing, as we had in the beginning, many of the different outbreaks that have happened and some of the mitigation measures that have been put in place really since 2000, so long before the COVID pandemic. And I will be speaking to some of these. I think just to note the R&D blueprint, the review of the international health regulations known as the IHR, and then the INB, which is the negotiating body, which is looking at the pandemic accord. So these are some of the things that are happening at global level. So some of you may have heard about this. It's called the HEPR, the Health Emergency Prevention, Preparedness and Response and Resilience Architecture. It's now the global architecture that's being put forward. And this comes from basically on the left-hand side, there was many independent reviews from COVID trying to understand what are the lessons learned and the recommendations to move forward to have a stronger health emergency system globally. And they identified 3 key areas, which was linked to global governance, financing systems, establishing financing systems, and then ensuring that there is a structured emergency preparedness and response system. So this is the pie in the middle, and then key to all of that are the principles of equity, inclusiveness, and coherence. And on the right side, you see the 5 circles. So these are now the systems that are in place for response. It needs to have a good coordination. It needs to have collaborative surveillance. There should be access to all the countermeasures. Consider the community protection, and then ensuring that there's safe and scalable care. You can see on the bottom right. And part of that is infection prevention, control, and WASH. So for the pandemic agreement, this is still under development. It was supposed to be presented at the WHO Assembly in 2024. However, they couldn't come to a full agreement. But this is hopefully going to be a legally binding agreement, which will ensure much of the things that are required with respect to coordination. And just to highlight, the key issues pending are linked to One Health, equal access and opportunity in technology transfer of vaccines and therapeutics. So with respect to other areas where there's reforms, the IHR, the International Health Regulation, there's amendments happening to that as well. One, they're looking at the definition of a pandemic emergency has been updated, but they've also are committed to strengthening access to health products and, of course, establishing this finance mechanisms. So once again, the IHR is also being updated based on need to do this. Another initiative now, which has been launched and activated, is what they call the Global Health Emergency Corps. And this is now basically an emergency health workforce which can be activated and mobilized to support countries at the beginning of outbreaks if they have limited capacity. And then in the area of research and development, there is the WHO Research and Development Blueprint platform. And this has there's just been a recent publication this year where they have now shifted their strategy, and I think this is I really like this. The concept on the left-hand side, you can see that what they're showing there really was the idea of, if you're looking for your keys where there's light, but actually your keys are somewhere else, so we're looking in the wrong place. And so how does that transfer into the research? What they're doing now is that instead of prioritizing specific pathogens, they're prioritizing families, so the whole coronavirus family versus just looking at COVID-19 with the anticipation that potentially next pandemic could be in one of the other sublineages. So this is the focus for the research moving forward. And that was really all on the global level with respect to what's happening in the emergency kind of area. But here now focusing on IPC specifically. Hopefully you've heard about the global strategy. So this is really a turning point for IPC, and this is about, as you can see there, the vision. And this is really about trying to mobilize countries to implement the IPC programs at national level and facility level. So this has been launched, and now they're in the middle of developing the M&E framework. So these are all the strategic directions you can see there. There's 8 of them. And then, of course, at facility level, we still have the core components. We have the minimum requirements. And these are just to emphasize that the tools are there on what needs to be done. Really, it's about implementation. And then finally, just to mention on the component of IPC in the context of emergencies, if we're looking from the frame of mind of emergencies, we have preparedness, readiness, and response. And we know that the more prepared and ready we are, the smaller the curve will be and the less exponential. So in light of that, the WHO has also developed a framework and toolkit which focuses on the key IPC activities that should be implemented during the preparedness, the readiness, and response phases. And these activities, there's 10 here, many of them are cross-cutting with the same activities that happen during normal IPC programs. However, it focuses also on things such as ensuring that you have surge capacity, human, financial resources, logistics, PPE supplies. It emphasizes the importance of testing the system with simulations, and really also making sure that there's a coordination mechanism in place irrespective of the phase. So this is just an example of what the actual interventions look like. This was a publication in the BMJ, and it's summarizing the guidelines for COVID, the IPC guidelines. And you can see here the same concept of amplification in the health facility and in the community and globally, and what are some of those mitigation measures. So the good news now is we know what they are. And so, back to the beginning, are we better prepared to respond to pandemics? You can see here there's a lot of different elements that are required. It's a complex environment, but there is hope moving forward with some of the tools and reforms, and really, I think the pandemic accord as well on a more global level. So in conclusions, epidemics and outbreaks are continued to increase in frequency, scale, complexity, impact, and they do pose a major risk to the global health security. Past outbreaks and the COVID pandemic have exposed some of the challenges and gaps in IPC. There are active IPC programs which can strengthen health systems and mitigate the effects of any outbreaks. And the lessons learned from various outbreaks need to be applied. This is a really important piece. And then finally, we are at the turning point of IPC with this window of opportunity between all of the global IPC measures and strategy that are being put in place, as well as the architecture for emergency. With this, let's see what the future holds. So thank you very much. Back to you.
Thank you very much, April, for summarizing such an important topic in a short time. And April will be available during the coffee break to answer questions. But I just want to make two short comments. And I think it's important to realize that the COVID pandemic, with all the devastating effects, had a couple of positive points. The first one is it elevated the role of IPC in the communities. And the second is that for the first time, policymakers and politicians and ministers started listening to us as IPC people, and it taught us to work as a multidisciplinary in a multidisciplinary approach. We have time for one quick question with a quick answer so that we stay on track. Fred, please.
Thank you for the presentation. It was very helpful. In the past week in the U.S., two dichotomous things have happened. One, California has reinstated mask mandates in hospitals. But in in Idaho, several counties have banned public health departments from distributing COVID vaccines. And the Surgeon General of the state of Florida is discouraging people from taking the vaccine. So from your viewpoint, we have a plan in place. How confident are you that people at the local level are actually going to implement that plan and local governments are going to fund it?
That's a good question and a difficult one. Yeah, I can't speak to the confidence in the American setting. I mean, I think what you're highlighting is a really important piece, which I didn't touch on, which is about the trust, the community trust. And one of the things that has come out a lot in the literature is that once that trust is lost between the government and the community, it's very difficult to, if you're in the middle of an outbreak or a pandemic, to to control it, and that you have to regain that. And I think what you're showing there is in the complexity, of course, of the United States, but it could be any country, how different measures are being put in within the country, and what messaging does that give to the people. So I think that there's a lot of work that needs to happen, and it's something that needs to happen at local level. And one of the spheres I was showing there was community protection, and that's very much about community engagement, bringing on the leaders and having them speak to try to bring on board the community. So I think that's the only way forward with that, and that's also been shown in many outbreaks. There was an example during the Ebola in Liberia when they brought the military in to try to control a community, and it completely backfired. So that's an extreme case, but the point being that that needs to be a part of any type of strategy. I hope that someone answers it. Thank you.
Thank you very much, Dr. Boller, for an excellent session.